How much trouble would I be if I stole the Tyler Hughes' plaque and walked out? Green button. The big green arrow. Yeah, or there, you know. All right, I guess we'll get started. First paper is presented by Dr. Purdy, Outcomes of Colectomy and Proctectomy According to Surgeon Training, General versus Colorectal Surgeons.
Hello, and thank you for the opportunity to present today. Oh. Got it. Here are disclosures which aren't relevant to the current work. The scope of general surgery is exceptionally broad and diverse, encompassing colorectal surgery, minimally invasive surgery, hernia surgery, vascular, trauma critical care, HPV, thoracic, breast, endocrine, pediatric surgery, transplant, just to name a few. With the increasing information and techniques to master within the purview of general surgery, there's been a trend toward subspecialization after general surgery training. Colectomies and proctectomies are examples of operations that are commonly performed by both general and colorectal surgeons. As the number of colorectal surgeons has increased with time, so has the proportion of colorectal operations performed by fellowship-trained colorectal surgeons. This raises the question, does fellowship training in colorectal surgery actually improve patient outcomes? The primary objective of our study was to examine the in-hospital mortality rate after common colorectal procedures performed by general versus colorectal surgeons. We evaluated 3 operations: elective colectomies, urgent colectomies, and elective proctectomies. Our secondary objective was to examine the in-hospital complication rate for after common colorectal surgery operations by general and colorectal surgeons. Data were obtained using the Vizient clinical database, which includes aggregate data for inpatients admitted to U.S. academic hospitals and their affiliates. We searched the database using ICD-10 procedure codes to identify all colectomies and proctectomies performed from 2020 through 2022. We collected case characteristics, including the urgency of admission, elective or urgent, and primary surgeon specialty, general and colorectal. We also collected demographic information, including patient sex, race, and age group. For outcomes, we collected the in-hospital mortality rate and the in-hospital complication rate, which we defined as the proportion of cases with one or more complications. Cases excluded from the analysis included urgent proctectomies, cases performed in the setting of trauma, patients younger than 18 years old, and if the patient was within the database's highest risk category. Outcomes were measured separately for elective colectomy, urgent colectomy, and elective proctectomy. We used multivariate regression, adjusting for sex, race, and age group to compare outcomes between cases performed by general and colorectal surgeons. During the 3-year study period, almost 150,000 elective colectomies were performed, with a 50-50 split between general and colorectal surgeons. There were almost 72,000 urgent colectomies performed. The majority of these cases were performed by general surgeons, 76% for general surgeons versus only 24% for colorectal surgeons. Of the 44,000 elective proctectomies performed, colorectal surgeons performed 65%, while general surgeons only performed 35%. For demographics, there was almost a 50-50 split for all cases between females and males. For race, the majority of patients for all operations identified as white. For the age group, the majority of patients undergoing colectomies were in the 65 to 79 age group, while the majority of patients undergoing proctectomy were in the 51 to 64 age group. Overall, patient demographics were similar between cases performed by general and colorectal surgeons. Now for our primary outcome, in-hospital mortality rate. For elective colectomy, mortality rate doubled if the primary surgeon was a general surgeon as opposed to a colorectal surgeon. Urgent colectomy saw the highest mortality rate, with 5.1% for general surgeons and 2.3% for colorectal surgeons. Again, cases performed by general surgeons had double the in-hospital mortality rate. For elective proctectomies, cases performed by general surgeons saw a 50% higher mortality rate than those performed by colorectal surgeons. Now for a secondary outcome, in-hospital complication rate. For elective colectomies, the complication rate was 4.9% for general surgeons versus 3.9% for colorectal surgeons, representing a 23% higher complication rate for general surgeons. Urgent colectomies had the highest complication rates, with 12.1% for general surgeons and 10.4% for colorectal surgeons. For elective proctectomies, cases performed by general surgeons were 16% more likely to lead to complications than those performed by colorectal surgeons. In summary, we found that elective colectomies were evenly performed by general and colorectal surgeons. General surgeons performed more than 3 times as many urgent colectomies than colorectal surgeons, and the majority of elective proctectomies were performed by colorectal surgeons. After adjusting for sex, race, and age group, colon and rectal operations performed by general surgeons were associated with worse outcomes than those performed by colorectal surgeons. Compared to colorectal surgeons, elective colectomies performed by general surgeons had double the mortality rate and a 23% higher complication rate. Urgent colectomies performed by general surgeons had double the mortality rate and a 14% higher complication rate. And proctectomies performed by general surgeons had a 50% higher mortality rate and a 16% higher complication rate. One potential explanation for our findings is the volume-outcome relationship, which is the phenomenon that increased surgeon case volume is associated with improved outcomes. This trend has been well established in the literature for a multitude of operations, including vascular, pancreas, thoracic, and GI cases. For general versus colorectal surgeons, the case volume discrepancy can be seen starting from training. To meet the ACGME case volume requirements to graduate from residency, general surgery trainees must complete a minimum of 40 colon cases and 20 anorectal cases. To meet the colorectal surgery graduation requirements, fellows must complete 120 abdominal colorectal operations and 60 anorectal operations. So colorectal surgeon trainees must complete 3 times as many colon and rectal operations than general surgery residents, and all of their training is compressed into 1 year as opposed to being spread out over 5 years for general surgery trainees. It is not surprising that in our study, urgent colectomies saw the highest hospital complication and mortality rate. Urgent colectomies also saw the largest mortality difference between groups with an odds ratio of 2.08. Even though mortality rate was doubled when operations were performed by general surgeons performed more than 3 times more urgent colectomies than colorectal surgeons. This likely reflects the fact that general surgeons tend to take more emergency call. And also the fact that there are significantly more general surgeons in the workforce. According to the American Board of Surgery, there are over 31,000 board-certified general surgeons in the US, while there are only around 2,000 board-certified colorectal surgeons. In conclusion, in our retrospective database review of US academic hospitals and their affiliates, in-hospital outcomes after colectomy and proctectomy were improved when the operation was performed by a colorectal specialist. General surgeons still perform a large proportion of colorectal operations in the US, in part because of the limited supply of colorectal surgeons, with general surgeons outnumbering colorectal surgeons by more than 10 times. Our study did have several limitations. As a retrospective database study, there's an inherent selection bias, and there's a chance that there could be coding errors. Our outcomes were also limited to only in-hospital events. And since the database doesn't contain patient-level data, we did not have comprehensive data about each patient's comorbidities and risk factors, making it impossible to control for all potential confounders. Future studies should aim to further characterize and define the differences in outcomes between colorectal and general surgeons. Thank you.
This case will be discussed by Dr. Wasif from Mayo Clinic, and it will be closed by Dr. Nguyen.
Thank you to the WSA for the privilege of discussing this study. Congratulations to Dr. Purdy and co-authors for an excellent presentation and study. The evolution of general surgery over the last 2 decades has been commented on and discussed in many surgical meetings as well as presidential addresses. Reactions to this change have ranged from defiance to resigned acceptance to angst for the good old days. Procedures that were once considered the exclusive provenance of the general surgeon have been encroached on by subspecialists. Ask 10 members of this society the same question, what is a general surgeon? And I think you will get 10 different answers. This study comparing outcomes between general surgeons and colorectal specialists when performing colectomies and proctectomies adds fuel to the fire, adds to the debate. So I think this is very provocative and interesting data. I have the following questions. In your study, 1 out of 3 patients underwent urgent colectomy. Of these, as we saw, 76% were performed by general surgeons and only 24% by colorectal surgeons. This population was also, this is a higher risk population, as we know, with expected worse outcomes. Now, you did control for sex, race, and age group, but not for comorbidity. Can the results of worse outcomes of urgent colectomy performed by general surgeons be explained by selection bias alone and residual confounding? My second question is more of a comment. I would welcome some thoughts on from yourself and your co-authors on just how actionable this data is. The results show that general surgeons have worse outcomes for colectomies and proctectomies, whether they're urgent or elective. The reality of it, though, is that the bulk of this work, especially in the urgent setting, in the United States, is being done by general surgeons. As of now, and in the medium to near term future, it is unlikely that there will be enough workforce of colorectal surgeons to pick up the remaining part of this work. So how do we resolve this dichotomy between the outcomes you presented and the realities of the workforce? Thank you.
Well, first I want to thank the association for the opportunity to present our data, and thank you, Dr. Nabil, for your astute comments. So your first question was related to the result of the worst outcome in the general surgery group because of selection bias, and the answer is yes. We only have preoperative comorbidities and patient characteristic to risk adjust for, and the urgency and emergency of the operation is hard to adjust for that because we don't have patient-level clinical information. And particularly what I'm saying is really the reason for the emergency nature of the operation. The risk of mortality is completely different in a patient with a perforated colon that's concealed and patient stable versus a patient that's perforated, freely perforated, and has sepsis and on a pressor. So you know where I'm trying to get at is that we need patient-level information to actually do a true adjustment. Unfortunately, this database, we don't have that. So this is only a provocative paper to stimulate additional evaluation on this subject. So I wouldn't say this is the end all. And your second question is about how actionable is this data? For the urgent colectomy, I don't think there's much actionable data because it's like you stated. Right now we have 2,000 colorectal surgeons and more than 30,000 general surgeons. We can't have our colorectal surgeons specifically take call for these day in, day out, even if the data demonstrated better outcome. Number two is that if you look at the elective operation, even though we say that the mortality associated in the general surgery group is higher, 2 times higher, but these are safe operations, doesn't matter who does them. Might be a general surgeon, might be a colorectal surgeon, it's less than 1%. Our outcome for colorectal surgery are very good. But with that being said, for the elective operation, in any center that has a colorectal surgeon right now, majority of the elective work are being referred to the colorectal surgeon. That's at our place, and it's at most places. We specifically looked at the data from University of California, 5 campuses, and see how many of the elective colectomy were done by colorectal surgeon versus general surgeon. 75% are being done by colorectal surgeon. So that is saying that the referral pattern for colorectal pathology elective tends to go to the colorectal surgeon.
Karen Brazel from Oregon Health and Science University. I have a question, actually 2 questions related to the Vizient database. And you talked about in the presentation and in the discussion about the lack of patient-related factors, but you excluded the highest risk group. And I'm curious as to how you defined the highest risk group without patient-level factors. I'm also curious, as somebody who has been asked by the colorectal surgeons to do an urgent colectomy and also to do some elective work, what that usually means is they think the patient is too sick and they want me to take care of it more expeditiously than they are able to do in their schedule. And showing a particular bias. So I'm wondering if there are data in the Vizient database that show how often when these cases are done, is there actually a colorectal surgeon available when these cases come in to get them to the operating room? Because although I don't doubt your conclusions, I worry very much about implications for access to care for patients.
So let me clarify about the VISIN database. It does have patient-level data. Unfortunately, as the researcher, we're not able to access the patient level. So what we can get is accurate data. So we use the search engine and we able to get the aggregate data. And so we can't really drill down to the specific patient level. And also the VISIN has their own relative risks. So they classify the patient as low, moderate, high, or extremely high risk. So they classify, and these are primarily based on preoperative characteristics, sex, age, comorbidities, etc. So they do risk adjust the patient for us, but they don't risk adjust that the patient are undergoing a perforated colon and the patient is septic and on a pressor. So that level of adjustment is impossible. Regarding your second comment regarding to the data available about if there is a colorectal surgeon available, what we noticed that in this particular database that not all institutions have colorectal surgeon. There were 850 center, so either an academic center or community affiliates has general surgeon performing all these colorectal operations. But when you look specifically at the colorectal group, there was only 338 center that actually have colorectal. So there are certain center that don't have a colorectal surgeon. So that is also a limitation.
Tyler Hughes from Slides. Good to see you again. So you said this was a provocative paper, and therefore I am provoked. But
Go for it.
General surgeon. But
Do we have a colorectal surgeon in the room, by the way? No. Okay. That's
So
good to
see,
know. That's good to know. I just
thank
wonder
you.
if there's a.
I'll defend the
that's the
colorectal surgeon if
question
need be.
at 5 o'clock in the afternoon in ED. Is there a colorectal surgeon in the room? And but I do think this will be a provocative paper if it's published.
Yeah.
And I can see the New York Times headline, general surgeons twice as deadly as colorectal surgeons, which, as Karen points out, could be, a problem for access to care because they'll frighten patients away. What do you think we can do to get a little better view of this? Could we use a NISQIP study to compare it? And how do we address the elephant in the room that, most of the time if I'm called in to do a colon, this patient is not looking too good. And I'll stand behind the usual defense. My patients are the sickest ones on the block, but of course. So how do we sort this out? Because every good paper stimulates another good paper. What's your next step?
Well, I would start off with what I kind of stated already, that the risk of mortality undergoing colorectal surgery is very low. We just show it to you. It doesn't matter who does them. And that's kind of, we project that image in the paper that although these are statistical findings, 2 times of higher mortality, really it's 0.5 versus 0.25. That's exactly what it means. Versus the prospective is like 0.3 versus 0.2. So these are safe operations. We're not talking about a major drastic change here. And I get it, the urgent and emergent group are the outlier, where there is a little differential, 5% versus 2.5%. So there are differential, but I would say again, we are very, we stress the importance that we don't have the specific patient level data to really nail that down. What can we do in the future? I would say a prospective study. That's an easy thing to do, multi-center prospective study, and just capture the data. That will be the easiest way to do it rather than looking at another database.
Hi, John Santino from Oak Lawn. My question is, when you say general surgeons, are you talking true general surgeons, or acute care surgeons? Which one are, or both?
Well, acute care surgeon are a general surgeon, so it truly, yeah.
Not necessarily. Acute care surgery, they do a fellowship, they train in all these special, a general surgeon is someone who goes out into private practice right after residency, if you take the definition as a purist. So are these general surgeons without fellowship, or are these ACS trained general surgeons?
So the categorization of the visit database is general surgeon,
You,
board certification in general surgery. So it's hard to separate between the two exactly what you're saying, but it will be difficult to
so
separate that.
we don't know.
We don't know.
Okay, I mean,
Yeah.
and the other comment is, again, there's so much missing data from this. I mean, are they getting hooked up in a patient that's too sick? Are the ones that getting colostomies the ones with the better outcomes because they won't get an anastomotic leak and die? I mean, there's no way to tell this from this information.
Well, that's what we were talking about, the limitation of this database, but
Well,
I can tell.
I want to be more specific.
Yeah.
I mean, these are questions that everyone's kind of skirting around, and I can't understand how this paper even, can be presented with all that data missing.
It is
I mean,
clearly
hard-
that he
yeah.
too is provoked. That's what I got from that.
That's why I asked if there's a colorectal surgeon in the room.
We'll make this quick.
Yeah.
I apologize. We're going to go ahead, but we're going to move to the next very quickly. Go ahead.
Okay, Tim Nelson, I just want to, Tulsa, Oklahoma, I'm a general surgeon. I did just come off the colorectal board. I was the general surgeon on it. It's not really surprising data, though. These people they have 3 times the amount of colorectal experience because they have their general surgery experience, plus they have this. And people who have more training should be better at what they do. I mean, I know this is going to irritate general surgeons because if it's not true, then why do we even have fellowships? So I think it's not shocking data. I do think your point about it might be a very, very small, and maybe it's just the thickest or most complex pelvic cases, but there's got to be a reason to do that additional training. Otherwise, if someone's not better at it, why would you do additional training?
But not only that, our field is leading down to subspecialization. This is general surgery. They have just general surgery right now. I would say it's very low, right? Because everybody is a specialist. I'm a general surgeon, but I'm a specialist. I only do foregut. That's all I do. And if I have a colorectal pathology, you can trust that I will be going to a colorectal surgeon. So, thank you.
Next paper will be presented by Dr. Demare, Genomics and Transcriptomics Landscape of Wild-Type Medullary Thyroid Cancer and the Potential Use of MAPK Targeted Therapies.
Thank you to the organization for the opportunity to present our paper. And this includes our disclosures. Note that several of the co-authors are employees of Caris Biosciences, where the sequence is done, but they have a research division that collaborated with us on the analysis. Neither the first author or myself have a financial relationship with Caris. Medullary thyroid cancer is an uncommon thyroid cancer, usually cited about 2% thyroid cancers that originates from the calcitonin secreting parafollicular cells. About 75% of the medullary thyroid cancers are sporadic, that is, they're not attributable to a germline mutation in RET. And of the sporadic, about 45 to 70% are driven by the RET oncogene mutation. And there is an approved therapy, selpercatinib, which is a targeted drug against RET. We, however, don't have specific targeted drugs for wild-type RET or medullary thyroid cancers that don't harbor a RET mutation. So therefore, we analyzed the genomic alterations and transcriptomic signatures of wild-type RET medullary thyroid cancers with the goal of hopefully finding therapeutic leads. Just a bit of background, the MAP kinase pathway is well known in cancer, and this is a very simplified prototype, but you have a ligand bind to a receptor that activates downstream signaling in KRAS, BRAF, MEK, and ERK. And this is well known in lots of tumors and targetable, for example, melanoma, where a dual BRAF inhibition with a BRAF inhibitor and a MEK inhibitor has efficacy. So our method for this paper is we did a retrospective analysis of the data on 160 medullary thyroid cancers that was submitted for clinical sequencing. This included RNA and DNA sequencing, whole exome and transcriptome. We calculated a MAP kinase activation score using an expression profile of 10 MAP kinase associated genes, and this was published in Nature in 2018 as a validated endmark. Did gene set enrichment analysis for looking at other pathways, and we defined, using again standard literature data, for example, in lung cancer, PD-1 expression as immunohistochemistry positive and greater than 2+ and greater than 5% of cells. Tumor mutation burden was calculated as more than 10 mutations per megabase. We did quantiseq RNA deconvolution to determine interferon gamma and looked at the immune cell fractions, and then looked at expression of interferon gamma as markers of immune signatures, and all our statistical analyses were corrected for multiple comparisons. This is a summary of the clinical data, which I'll tell you is already limited in terms of we don't have stage, and it's one of the limitations of our papers. But roughly a third of the tumors were RET mutant wild type, RET wild type. The age and gender distribution was fairly equal. On the bottom is a lollipop plot that shows the mutations, and the taller the lollipop, the more frequent it was. You see the most frequent mutation was in the 918 codon, which was in the tyrosine kinase domain. The second most was in the transmembrane domain at codon 634. This is a heat map where the dark black shows a mutation, and the most common mutations in the RET wild type medullary thyroid cancers were in the MAP kinase pathway, most frequently in HRAS and KRAS, but also in BRAF or NF1. The other notable pathway where we saw mutations was in genes related to DNA repair, such as ARID1A, BRCA1, and ATM. This graph shows the MAP kinase activation scores, and RET also activates MAP kinase. So on the bottom left, or the left, you see the red and the dark blue box and whisper plots, which shows the similar MAP kinase activation scores. However, in the next slide, where they took the other two blue squares, there is a difference in activation of MAP kinase based on whether there was a mutation in a gene in the MAP kinase pathway, such that the mutation showed increased MAP kinase score. On the right side was the depiction of the gene enrichment analysis, and the tall bar on the top two graphs show that angiogenesis was overexpressed in the RET wild type genes. And this makes sense because cabozantinib is a drug that targets VEGF and has shown efficacy in medullary thyroid cancer. This is a graph, or a series of graphs depicting predictors of immune response. What we saw was that if you look at the mutant RET, that the tumors had increased proportion of cells that were natural killer cells, CD4 and Tregs. The wild type RET had increased population of M1 macrophages. And the top right is the interferon gamma score, which was also increased in the wild type RET and most increased in the MAP kinase wild type RET cell population. On the bottom right of the screen shows the immunohistochemistry for PD-L1, which increases with a wild type RET and MAP kinase, and also there was a higher proportion of cells that had MSI high, or microsatellite instability high tumors, and also increased TMB. This data taken together suggests that wild type RET tumors may be more responsive to immuno-oncology agents. So in conclusion, I'd like to say that the RET wild type medullary thyroid cancers frequently harbor MAP kinase pathway mutations. There's also an increased frequency in the wild type RET tumors of predictive markers of response to immunotherapy. So the MAP kinase targeted therapy, possibly in combination with IO, warrants additional investigation as a treatment for medullary thyroid cancer. And thank you for your attention.
This paper will be discussed by Dr. Reinhardt.
Yay, more endocrine. First, I would like to thank the Western Surgical Program Committee for giving me the chance to discuss this interesting manuscript, and I'd also like to thank the entire team involved with bringing this manuscript to fruition. The logistics alone of making this multi-center genomic study could warrant its own paper. After reading through your literature, I found one interesting manuscript, Personalized Medicine, The Future is Not What It Used to Be, in which you discuss genomics and the potential for genomic-specific treatment of certain cancers. This was published over 13 years ago. Kudos to you and your team for practicing what you preach, which brings us to this current study. This paper is the next step in personalized targeted therapy in medullary thyroid cancer and the first deep dive into the molecular alterations and immune-related features of the wild-type RET-mutated medullary thyroid cancer. My first question. You identified one of the shortcomings of this study, not including clinical annotations, such as having received MAPK pathway treatments. How will you address this going forward, and is there a possibility of including clinical parameters such as tumor size, tumor markers, nodal status at diagnosis, et cetera, to better gauge the extent of disease and possibly predict future response to treatments once these modalities are better studied? This is also a segue into my second question. Since these cancers are usually diagnosed on FNA, how do you envision your findings being utilized on the current genomic tests available, such as FIRMA? And is there any role for neoadjuvant treatment, since 80% of these patients present with distant metastases on diagnosis? And my last question, what are your plans to study the molecular oncogenesis of the wild-type medullary thyroid cancer in order to facilitate more treatment options? Again, thank you, and I look forward to your responses.
Thank you for your, first of all, for, I guess, recognizing that that was my presidential address for the AES, so thank you. Yeah, I've had a longstanding interest in using genomics to find therapies. Certainly one of the limitations of this genomic database is, is a lack of full clinical annotation, which we don't have. But I think it's probably pretty safe to say that our population of tumors is skewed toward more advanced, because those are the patients that get clinical sequencing. The smaller tumors that are completely resected and the patients do well probably don't get sequenced, or less likely to get full sequencing. They may get RET sequencing because that's pretty much standard of care, at least to find out if you have a germline mutation and the patient's at risk or their family members are at risk for other tumors. Preoperative FNA is interesting. They will pick up RET, Afirma, and Assuragen, the two major companies that do most of the sequencing on FNA samples for thyroid. They do pick up these mutations. I'm not sure, well, it helps you make a diagnosis, which may change your operative plan, but I'm not sure there's a role yet for neoadjuvant tumors, except for the odd tumor where the patient may present with local invasion, encasement of the recurrent laryngeal nerve. And for thyroid cancer, that's something that's being talked about at the International Thyroid Oncology Group as a trial, in particular for papillary and follicular, but the role of neoadjuvant therapy. An unanswered question also is the role for adjuvant therapy. So if you have a RET mutant tumor, would the patient benefit from adjuvant selpercatinib, for example, after surgery? Because, as you mentioned, a lot of patients have occult nodal metastases already, or even unrecognized liver metastases is the most common things. Lastly, as far as where we might head with this next, this paper was really prompted by me trying to convince a company that makes ulixertinib, which is BVD 253, trying to convince them to do a clinical trial in medullary thyroid cancer. It's an ERK inhibitor, so downstream on that MAP kinase pathway. So I'm saying I think there's an unmet need. You should do a clinical trial with ulixertinib in wild-type RET medullary thyroid cancer. So that prompted us to really try to get the preclinical data to convince them to maybe take a look at this indication. Thank you for your comments.
Thank you. The next paper will be presented by Dr. Latu, Outcomes for Hepatocellular Carcinoma Following Liver-Directed Therapy versus Surgery.
Good afternoon, everyone. My name is Mike Lateau. I'm currently a general surgery intern at the Cleveland Clinic. I'm here today to talk to you about a project I did under the mentorship of Dr. Marshall Baker when both of us were still at Loyola, investigating outcomes following surgical resection versus liver-directed therapy for hepatocellular carcinoma. We have no closures to report. Hepatocellular carcinoma continues to carry a poor prognosis, with 2-year survival less than 50% and only 10% surviving for 5 years. Current treatment algorithms recommend surgical resection as a first-line treatment for patients with solitary tumors and preserved hepatic function. Patients meeting Milan criteria should also be considered for transplantation. However, a majority of patients present with disease at advanced stages that is not amenable to surgical resection or transplantation. Multiple interventional modalities have been developed to provide local disease control in these patients, including microwave and radiofrequency ablation, transarterial radioembolization or TARE, transarterial chemoembolization or TACE, and radiotherapy. Several groups have observed these interventions offer local disease control perhaps as effective as resection, with favorable post-procedure morbidity and mortality, particularly when considered relative to the potential for hepatic decompensation associated with hepatectomy in cirrhotic patients. Most studies evaluating the efficacy of these interventional approaches are single institutional series without a comparison or control group. Few compare transcatheter and percutaneous methods of liver-directed therapy to surgical resection. These have generally been small series with limited capacity to adjust for comorbid disease. It is unclear if liver-directed therapy alone is an effective definitive treatment, or if patients initially treated with liver-directed therapy should undergo surgical resection following their initial treatment. We use data from the Veterans Affairs Corporate Data Warehouse, or VA-CDW, to compare short and long-term clinical outcomes for patients treated with either surgical resection or liver-directed therapy for localized hepatocellular carcinoma. Our hypothesis was that rates of disease-specific and overall survival for liver-directed therapy would be similar to those for partial hepatectomy. The VA-CDW is a national-level data management system that houses clinical, administrative, and financial Veterans Health Administration data and allows for longitudinal follow-up of veterans treated for any condition in any VA facility. The listed ICD codes were used to identify patients diagnosed with and treated for hepatocellular carcinoma within the VA system between the years 2000 and 2017. Exclusion criteria were as follows: distant metastatic disease, treatment with liver transplantation, definitive treatment with SBRT, and surgical resection in combination with liver-directed therapy. Univariate comparisons of demographic characteristics, disease characteristics, and treatment utilization were made between patients undergoing surgical resection alone or liver-directed therapy alone. Multivariable logistic regression was used to identify factors associated with undergoing resection relative to liver-directed therapy. Cox modeling was performed to identify factors associated with risk of death. This model adjusted for multiple variables thought to be associated with clinical outcome. Patients undergoing resection then 1 to 3 propensity score matched to those undergoing liver-directed therapy. Patients were matched for the factors listed on the slide. 30-day mortality between the matched cohorts was compared using chi-squared analysis. Overall survival and disease-free survival between matched cohorts were compared using the Kaplan-Meier method. 5,940 patients with hepatocellular carcinoma and meeting inclusion criteria were identified in the VA-CDW. Of the 5,215 patients undergoing liver-directed therapy, 2,177, 42% underwent radiofrequency or microwave ablation, 2,240, 43% underwent TACE, and 375 or 7% underwent TARE. 1,091 patients receiving TACE also underwent treatment with adjunctive external radiation. Of the 725 patients undergoing surgical resection, 432, 60% underwent partial lobectomy, 140, 19% underwent wedge resection, and 157 or 22% underwent right or left lobectomy, 30 or 4% underwent trisegmentectomy. This table depicts the results of univariate comparisons of patient characteristics. Patients undergoing surgical resection tended to be older, were more likely to be of Black race, were more likely to have diabetes, and were less likely to have used tobacco. Those undergoing resection were also more likely to have disease at advanced clinical stage. This slide depicts the results of a multivariable logistic regression predicting factors associated with surgical resection. In this analysis, we found that older patients and patients with clinical stage 3 disease were more likely to undergo surgical resection. This table shows the results of our Cox proportional hazards modeling predicting factors associated with mortality. In this model, patients with higher BMI and advanced clinical stage had increased risk-adjusted odds of death. Surgical resection is associated with a marginal decrease in risk-adjusted odds of death relative to liver-directed therapy. Surprisingly, comorbid disease was also associated with a marginal decrease in overall mortality. This table shows the univariate comparison of cohorts following propensity matching. 725 patients undergoing surgical resection were successfully matched to 2,175 patients undergoing liver-directed therapy, as evidenced by standardized mean differences less than 0.1 for the factors we included in the match. This is the comparison of outcomes for propensity matched cohorts following either surgical resection or liver-directed therapy. Patients undergoing surgical resection were nearly 3 times as likely to experience post-treatment mortality compared to those undergoing liver-directed therapy. On Kaplan-Meier analysis of matched cohorts, there was no difference between those undergoing surgical resection relative to liver-directed therapy in disease-free survival, median overall survival, or percent 5-year survival. In summary, we found that older patients and patients with clinical stage 3 disease were more likely to be treated with surgical resection relative to liver-directed therapy. We found that liver-directed therapy had reduced post-treatment mortality while affording rates of overall and disease-specific survival statistically similar to surgical resection. This study does have some limitations worth mentioning. As a retrospective analysis, it's inherently subject to selection and omitted variable biases. Additionally, the VA CDW only captures patients treated at VA facilities who are predominantly white and male. Our cohort is significantly skewed towards that demographic and may not be generalizable to other patients or patients treated outside the VA clinical network. There's also little in the way of detail regarding severity of underlying liver disease and comorbid disease. For this reason, we have a limited ability to adjust for variation in disease severity. It is entirely possible that patients undergoing liver-directed therapy are more frail than those undergoing surgery, that outcomes for liver-directed therapy compared to resection would be improved with more accurate adjustment of our survival modeling. Despite these limitations, we find that liver-directed therapy is associated with long-term survival profiles that are equivalent to surgical resection for patients with localized hepatocellular carcinoma. The fact that disease-specific and overall survival profiles for liver-directed therapy and resection are essentially identical would indicate that liver-directed therapy by itself is a safe and effective definitive therapy for patients with localized HCC. Liver-directed therapy also tends to be more well-tolerated than surgical resection, with studies demonstrating reduced post-procedure pain, length of hospitalization following the procedure, and reduced post-procedure hepatic decompensation, although we did not directly assess those factors here. Liver-directed therapy also has the benefit of not compromising future treatment options. Additional liver-directed therapy, surgical resection, and liver transplantation can all still be performed following initial treatment with liver-directed therapy. We conclude that liver-directed therapy should be considered an effective definitive treatment modality for patients presenting with localized hepatocellular carcinoma. Thank you to the Western Surgical Association for the opportunity to present our work. Thank you to the audience for your time and attention. We're looking forward to discussing our findings.
This paper will be discussed by Dr. Clary.
Well,
and
thank you
closed
to
by
Dr.
Baker.
Sorry. Thank you to Dr. Leteau and Dr. Baker and the association for the privilege of being able to present or to discuss this important contribution and to review their very thoughtful manuscript ahead of time. As nicely outlined by Dr. Leteau, there remain substantial questions regarding the relative efficacy of different local treatment approaches for patients with localized hepatocellular carcinoma. This question has been the topic of numerous publications in the literature, including a randomized trial, a few meta-analyses, and a myriad of retrospective registry and institutional experiences. Most studies point to a modest long-term benefit of resection in the management of early-stage patients who, importantly, are candidates for both resection and the specific liver-directed treatment in question. They also expose the increased short-term morbidity and mortality rates associated with partial hepatectomy when compared to non-resection local strategies. The VA data set used by Dr. Leteau has a number of potential advantages compared to other large registries when considering the relative efficacy of resection and other liver-directed therapies, not the least of which is the reporting of disease-specific survival and other long-term follow-up. In clinical practice, though, the choice of which local therapy to recommend is quite nuanced and takes into account size and location of the mass, the anticipated future liver remnant size, the degree of pre-procedural liver dysfunction, other comorbidities, and whether or not the patient is a candidate for transplantation. In this context, the debate about optimal local treatment strategies is, in my view, better thought of as multiple debates pertinent to specific subpopulations of patients with HCC. For example, thermal ablation and embolization strategies are typically applied in very different patient populations defined by tumor size, number, and location. Larger tumors and those in challenging locations are typically embolized, whereas small lesions surrounded by wider margins of parenchyma are more often ablated. Another example, patients who are being considered for transplantation are very uncommonly ablated with percutaneous approaches. Despite this, Dr. Leteau and colleagues chose to collectively assess the efficacy of very different local options against resection instead of performing independent analyses of ablation versus resection and embolization versus resection. A few points from the data set I think are worth emphasizing. The average age of their patients is 74, which is 10 years older than the average HCC, or the average age at diagnosis across the US. And 99% of their patients are male and 65% are white, again, leading to some caution about generalizing these findings. Their data set does not include tumor location, which greatly affects decisions about local treatment options and which also are associated with patient outcomes. Importantly, the degree of liver dysfunction was not included as a variable or a criteria for exclusion or inclusion in this analysis. And also, almost 90% of the VA patients receive liver-directed therapies as their first-line localized therapy, likely reflecting patient comorbidity issues and perhaps access to complex HPV surgery and multidisciplinary expertise. With that, I have three questions. Number one, can the authors comment on the rationale for such an approach of collectively assessing ablation and embolization approaches and perhaps the implications of doing so? Two, why do the authors intentionally exclude patients receiving external beam radiation in this analysis? Recent parenchymal sparing radiation techniques have demonstrated reasonable rates of disease control comparable to other local treatment options. And then lastly, does the VA clinical data warehouse contain the variables necessary to calculate MELD? And if so, why do the authors not embed this into their study, either as a variable or perhaps as a strategy to limit the analysis to patients with very low MELD? Again, thank you very much for this important contribution.
Thank you, Dr. Clary, and thank you to the association for the opportunity to present our work. That reading and assessment of the paper was very thorough, and I think you hit on a number of important issues. We started this project because we wanted to look at what I would consider sort of a real world from the VA standpoint, evaluation of how liver-directed therapy stacks up against resection. And with the way that we were tending, when I was in practice at the VA, to manage these patients, we would make a decision about surgery versus liver-directed therapy, and then we would talk to radiology, and the radiologists collectively with us would make a decision about what the right form of liver-directed therapy was. So we were really trying to kind of mirror that and just compare outcomes for patients that we were treating in that way. So we initially decided to group them together as a collective group of techniques. We have subsequently, and in the process of doing this project, peeled out and looked at each of them separately too. And it always looks the same. There's just no measurable difference in survival or recurrence rate, even when you peel out Y90 or ablation and compare that to resection. But your points about controlling for tumor location and size, it's difficult to do that. We do the best we can, I think, with pretreatment clinical stage, but it's hard to control for all those factors specifically. With regard to the SBRT question, so without question, SBRT or external radiation is an effective method of liver-directed therapy, and we have had versions of this project with radiation included. Conclusions are still the same. When we were talking about how to present this to the meeting and what I wanted it to look like, I tend to be somebody who looks at SBRT or radiation as sort of the last treatment alternative, because it has, in my experience, been so hard to operate in those patients after they're radiated. You tend to get perihepatic fibrosis. If you're radiating a peripheral tumor, it can be hard to liberate the right lobe or left lobe from the diaphragm. You end up doing partial diaphragm resections when you don't feel like you need to. With central tumors, the porta tends to get fibrotic and hard to work with, and so I tend to look at SBRT or radiation as something to bring into the mix after excluding the others, and just honestly wanted to look at how Y90 and microwave stacked up against resection to the best that we could. With the question about MELD, so the VA data systems are robust, almost to a fault. They're incredibly gigantic data sets, and that makes them a little cumbersome and hard to work with. And to Mike's credit, it took almost 4 years to get this far. Mike started out in our lab learning R, learning Stata, learning SAS, had to learn SQL to code in the VA system, and then getting through the IRB and getting all that done, got down to a point where we were doing this, and then we were finding a lot of missingness in the variables that you'd use for MELD, and we just didn't feel like we could really capture it completely. What we were finding, though, is that most of these folks, as you'd expect, had sort of preserved melds. That, the ones that we could see, their melds were ranging from like 9 to 12, which is, I think, what we see in practice most of the time. Folks with higher melds are either getting transplanted or they're not getting treated because they're too sick to get treated even with Y90. So we felt relatively comfortable putting the data out there with that in mind, that you probably just didn't need to adjust for MELD in this population because they were all relatively low melders. Having said that, there's no question that comorbid disease and age and all of that and expertise at in the VA health system affects the number of people being treated with liver-directed therapy in that system. There's just not a lot of folks doing liver surgery at the VAs around the country, and there are a lot more people doing ablations and things like that. And but having said all that, I still feel like it's hard to argue with survival curves that look as identical as these are. And it's nice to see disease-specific survival is going out even farther than 5 years. Yeah, it's rare to get that kind of data in any other source, from any other source.
Yuman Fong from City of Hope. 2 questions for you. First, it's almost never an either or in this patient population. Just having done it for 40 years, it's always, what do I do first, and what am I anticipating to do second and third and fourth, and how do I get somebody out 5 years and beyond? So do you have data on how many different treatments somebody had and as related to survival? And that's because the VA data set allows you to do that, because it allows continuous follow-up of these patients. The second question I have for you really is, in the last 5 years, Y90 therapy has become a little bit different. Besides using it to just treat focally tumors, now we're doing Y90 lobectomy so that we can not only control the disease, but do a atrophy-inducing procedure on one side while doing a hypertrophy procedure on the other side, so that we can subsequently do a resection of somebody who may not have be able to have it up front. So can you tell how many Y90 therapies were done, then followed by resection, and whether that population is different? And so really nice paper. Thank you for presenting it.
Yeah, so that great questions. And without any doubt, that's what we're doing in Utah too. This was all just single treatment, other than the guys that got TACE and radiation at the same time. But it was liver-directed therapy, and that's at one time, surgery, and that's at one time. And so we're looking at a different population. You can go back and do what you're asking, which is to look at sequencing, but that is hard to do. And so that was the next step. Mike graduated, I moved. We're going to figure out a way to get back to that, but it's going to take a little while. But you can do it, but it's a tough analysis to do in the VA, because you just have to, it's a bunch of coding that's really complicated. But in terms of hypertrophy and building into resection or subsequent, there's no question that that kind of planning happens with different patients depending on how multifocal the disease is, where it's located, how sick the patient is, how young they are. We just haven't gotten to that part of it yet. Thank you, though, for that question. Mark?
Yeah, Mark Trudy, Mayo Clinic. Marshall, great data, great presentation. I think everything that you put out there, I believe it's real. My only question has to do with, of the surgical patients, were they appropriately treated with surgery? We use BCLC criteria to determine whether, what treatment paradigm should be done. A lot of places do. You mentioned clinical stage. I'm assuming that was AJCC, not BCLC. Is there a way with your data to go back and put them into BCLC criteria to see, were these BCLC, up to A, or were they beyond, and therefore that's why the results show, worse outcomes? Thanks.
Yeah, this is a great question too. This is AJCC clinical staging, and we can, I think, with this data, go back and do what you're asking, but it will probably take another couple of years and another couple of students to do it. But yeah, just haven't done that.
Good night, UND Fargo. My understanding, this is encompassing from 2000 forward about 20 years. And similar to Dr. Fong's question in terms of type of therapy and quality, I'm curious in terms of the evolution from RFA to microwave at many centers during that time period. Did you look by period in terms of seeing if there's a difference by decade? Thanks.
Yes, that's another good question, and we haven't done that, but could do that. I think, we just haven't done it yet, but I would expect to see an increase in Y90 and kind of a waning sort of RF with microwave being used primarily as an ablative strategy in more recent years, but we just haven't done that analysis. Can be done. It's a good idea.
Thank you.
That's it. Okay.
Our final presentation will be done by Dr. Otway. I apologize up front. Palliative portomesenteric venous stenting for unresectable pancreatic cancer.
Good afternoon. My name is Stella J. I'm a general surgical resident in the University of Milano Bicocca, Italy, and I'm spending time at Mayo Clinic Rochester as a visiting research fellow. Thank you for having me here. Today, I will be talking about our experience in the palliative portomesenteric venous stenting for unresectable pancreatic cancer patients. We have nothing to disclose. Pancreatic malignancies are pathologically characterized by extrapancreatic extension that can lead to portal vein and superior mesenteric vein narrowing or complete occlusion with the development of venous hypertension. If left untreated, many patients can develop signs and symptoms including postprandial pain, diarrhea, gastrointestinal bleeding, due to the high-pressure variceal collaterals, and that can lead to non-malignant ascites. All of these can lead to the detriment of the quality of life with a poor performance status that can be an obstacle to the delivery of palliative treatment. Transhepatic portomesenteric venous stenting is a minimally invasive procedure that can resolve venous stenosis and short segment occlusion, and has already been reported in the post-operative setting by our group and others. However, its effectiveness as a palliative procedure for unresectable pancreatic cancer patients has not been well documented. So the aim of this study was to assess the technical feasibility and the symptomatic efficacy of this venous stenting in the palliative setting. We reported a single-center retrospective study in which 75 unresectable pancreatic cancer patients with portal vein or superior mesenteric vein stenosis or complete occlusion were included. All patients underwent venous stenting under fluoroscopic guidance. Here are the core demographics, and the most common reason for unresectability was either unreconstructible anatomy or metastatic disease. The most patients were symptomatic, and symptoms included postprandial pain, ascites, and gastrointestinal bleeding. The most common site of venous stenosis or complete occlusion were the portal superior mesenteric vein confluence, with 41% of patients with a complete venous occlusion at diagnosis. Despite that, all but one procedure attempted were technically successful. Post-procedure, 84% of patients started or continued their anticoagulation therapy. Median follow-up duration was 334 days, with 83% of stent patency at last follow-up, with a median length of stent patency duration of 207 days. Of all the symptomatic patients, 85% were able to achieve complete or partial symptoms resolution after stenting. Complication after the procedure were one failed stenting attempt due to the impossibility of recanalization of a chronically thrombosed vein. We also had 9 minor events, including 4 non-occlusive stent thromboses and 2 occlusive. Of those 6 patients, 5 were already under active anticoagulation therapy. We also had 3 major events, including 1 death 12 days after the procedure. After the procedure, 74% of patients were able to start or complete their chemotherapy and/or chemoradiation due to the resolution of their private symptoms. Of those patients without metastatic disease, 5 were able to undergo a surgical exploration after, of course, the venous stenting and the completion of chemotherapy and/or chemoradiation. Of those 5, 4 patients underwent a total pancreatectomy with en bloc venous resection and reconstruction, and 1 had a palliative gastrojejunostomy. We also had other 12 patients who are currently undergoing chemotherapy and/or chemoradiation and are going under evaluation for a possible future resection. This is an example of a patient with a portal superior mesenteric vein severe stenosis and associated pancreatic head venous collateral varices. Here on your left, you can see the venogram prior to stenting with the severe stenosis and all the venous collaterals. On the right, you can see the post-stenting venogram showing the excellent resolution of the stenosis and the decompression of all the varices. This patient went on to undergo a total pancreatectomy with en bloc celiac axis and venous resection, and a subsequent dual hepatic artery and venous revascularization. All of this with a very less blood loss due to the resolution of the previous collaterals. Here is a pathology specimen with indwelling venous stent removed. Here is another example of a patient with a neck tumor with a complete portal vein superior mesenteric vein confluence occlusion and the correlated varices. This patient had also a good distal and proximal targets. Here is the subsequent venogram showing the complete venous occlusion and all the varices. And this is the post-stenting venogram showing complete resolution of the previous occlusion with the decompression of all the hypertensive varices. Here is an intraoperative view of the involved venous segment previous stented. And this patient finally underwent a total pancreatectomy with en bloc segmental venous resection and a subsequent reconstruction with a cadaveric interposition graft, again with minimal blood loss due to the possibility of resolution of his varices. And here is the pathology specimen with the venous stent removed and blocked with the specimen. So in conclusion, transhepatic portomesenteric venous stenting appears to be a safe and effective palliative procedure that should be considered for selected unresectable pancreatic cancer patients to prevent or treat signs and symptoms of occlusive venous hypertension. Preoperative venous stenting may also be considered for potentially resectable patients to resolve their venous varices and have a safer oncologic resection, always in highly selected patients. Thank you very much for your attention.
This paper will be discussed by Dr. Doyle and closed by Dr. Purdy.
Thank you, and thanks to the Western for the opportunity to discuss the paper, and thanks to the authors for the great presentation and for sending the manuscripts well in advance for me to review. Now, the authors here, as many of you know, are well known for pushing the boundaries when it comes to pancreas resection, as we saw from some of the pictures here. Dr. Trudy and his colleagues have previously reported and presented at this meeting with great advances in pancreas resection with both venous and arterial reconstruction. In this study, however, they really focus on patients that generally get less attention, in my opinion, the unresectable patient and their palliation. Patients with unresectable pancreas cancer, for the most part, with occlusion or narrowing of the portal vein or SMV, were treated with IR stenting to improve symptoms or to alleviate risk of complications of an occluded portal vein, and obviously some went on to resection. So I have a few questions. In the paper, you talk a lot about the symptomatology of the patients as a reason to consider stenting, and the majority of patients appear to have symptoms pre-stenting. How did you assess accurately the patient's symptomatology pre and post procedure to really understand the patient benefit? I worry that some of the patients who had ascites may have had malignant ascites and not be related to the portal vein narrowing, or for example, the postprandial pain that patients were describing, was that just related to nerve invasion from cancer extension? And so really, how did you use any standardized questionnaires from the patients pre and post-op? I understand it was retrospective study, so that might be more challenging, but how do you really kind of convince me that the stenting is making a difference? Second of all, you treated several patients who were asymptomatic. Why did you do that? And does the risk of complications from the stenting procedure really outweigh the potential risk of a narrowed vein? And perhaps this was more in patients who you were planning to resect, but I would like you to elaborate on that, please. And then in the study, a few patients had a covered stent. I'm assuming the majority of the patients had a bare metal stent. Maybe you would tell us a little bit about the choice of stenting and also about the target. Do you have to have a distal target in order to put the stent in? I know certainly when we consider resection for these patients, we need to have a distal target. Is this required also for stenting, or could you actually recanalize a vein like Northwestern report for transplant with occluded veins by using the stent? And finally, does the location of the stent, of the stricture or the narrowing or the occlusion affect your ability to put in the stent? And were there many patients that you could not even consider for stenting based on the location of the stricture? Thanks again for the opportunity to discuss the paper. It was great work.
Thank you, Dr. Doyle. Before I begin answering just the genesis of all this, why are we talking about an interventional radiologic procedure at a surgical meeting? Because primarily, IR doesn't see these patients. They're referred these patients. So all these patients were referred specifically from myself and my colleagues, and then now more and more often our medical oncology colleagues who were previously unaware, that a lot of these symptoms are a result of a specific anatomical issues. This all started, even though this is an 11-year period, 98% of these cases were done in the last 2 years. This is a growing procedural practice. But initially started dealing with postoperative patients who develop strictures or stenoses after surgery. Patients are living much longer now, so we're starting to see the consequences of our operations, which we previously would not see them. And then we decided, well, if they do such a good job in our postoperative patients, can we now apply this in a palliative sense? You asked, how are these symptoms assessed? We don't have any real specific standardized assessment. You mentioned on the ascites, any patient with ascites, prior to any type of stenting, they'll undergo staging laparoscopy. That's something that we offer. Our group has made a concerted effort. Any non-metastatic patient that's seen at a Mayo Clinic in Rochester is seen by a surgeon, and that's part of the staging process, whether they're ultimately resectable or not. For adequate staging. So they've all had their peritoneal cavity evaluated to make sure this is not a malignant ascites, and it's most likely a venous hypertensive cause. The GI bleeding is typically similar. The postprandial pain that they experience, again, that's more subjective, but fortunately the majority of those patients did get resolution of that. So we're still working with some of our palliative care providers to get a better assessment of these patients so they can be adequately triaged for this procedure. You talked about asymptomatic patients. Did we help them or didn't we? I don't know. I can't answer that fully, but I do know that of all the asymptomatic patients that we did intervene on for a critical high-grade stenosis with the PV stent, none of them have progressed to develop symptoms. So we could argue that maybe we prevented those potential symptoms that they're often at high risk for. The question on, what type of anatomy is suitable, just like surgery, IR also needs a distal target to get to. The longer the segment of occlusion, the more difficult, and the longer duration of occlusion, the more difficult it is to get a wire across. So typically we tend to intervene early. If you have a 90% stenosis, we want to get there then versus waiting a couple months later and now they have a complete occlusion. It's very difficult for them to kind of snake a wire across that. But typically, if it's been down since diagnosis and it's been 9 months with treatment and it's been occluded that whole time, very unlikely are they going to get a wire. They just need to get a wire across. If they could get a wire across to a distal target, they could employ the stent. The majority of these are uncovered stents. Very rarely did they have to use a covered stent. That would typically be if there was a intraprocedural vascular injury and they needed to cover that for protection. And you also never want to put a covered stent in someone who has cholangitis, or do it at the same time as someone who has any active liver infection. Hope that answers your questions. Dr. Demir.
Thank you. Beautiful presentation. It's nice to add that to the armamentarium. I'm sure for a few selected patients, they can have quite a bit of ascites. I noticed that on all the images you showed, the splenic vein remains out. Are you assessing or having any salutary effect then on gastric varices, and have gastric varices that persist been an issue as far as GI bleeding or anything else?
It all depends on the anatomy. Some of the pictures we did show their splenic vein had already been occluded, but there are other patients that is patent, and there's a stenosis either at the confluence or distal in the SMV. Usually when they have splenic vein occlusion, as you know, they're either draining through the coronary or through gastropaploics and then coming back up, through an IMV. So if you could reestablish distal outflow, that tends to decompress all gastrosplenic outflow, and they tend to have less bleeding gastropathy as well. Marshall.
Mark, this is great work. And I think you just deserve to be congratulated for it. When I see the presentation, it's about palliation, and when I hear you talking, I feel like you're doing more than just for palliation. I mean, can you just give me a sense for what's happening in your head? Like, because we've got a bunch of people who have ascites but aren't really symptomatic, and I'm looking at their veins thinking they're not going to get through treatment without doing something to that. Let's stent them, and then you get some pushback from MedOnc or others that say there's no data to do that. I mean, are you guys stenting when it looks like it's going to be a problem, or are you only stenting when they have symptoms, or are you stenting patients that have ascites and are asymptomatic? I mean, how do you decide?
It's a great question. Again, we are stenting more and more, currently asymptomatic patients. It's very difficult to decipher what's a symptom from their, local regional complications versus treatment toxicity. And so this is now, we're all kind of educating each other. I'm pushing our IR guys and ladies to do procedures they're not typically comfortable doing, and getting more comfortable. This allows me to offer surgery to patients that I otherwise would not be able to offer a resection to, other than doing a mesocaval shunt intraoperatively. And it's also helping our medical oncologists to palliate these patients and recognize that there are other toxicities that they're having that aren't necessarily treatment related, they're tumor related. So we're all kind of working together to do the best for the patient. Dr. Fong.
Yeah, congratulations, Mark. I've been trying for 3 decades to get our MENONCs to let me do this, okay? And so now there's a little bit of data. Are you going back and matching it to people with imminent occlusion in the past and looking at survival? I bet you're getting better survival. And I would love for you to do a match series of scans. Second, why aren't everybody on anticoagulation? Why is it only 85%? And then my last question is, that patient that's out 1,600 days, 4.5 years, did that person get a resection or not a resection?
I believe that was a neuroendocrine patient that had an occlusion, so obviously better biology. I'm hoping that's great questions and future studies to look at. We're definitely going to be following these patients and then trying to see, whether their outcomes are better because of the stent or because they're able to complete their therapy or a combination of both. I'm not certain.
Jim Park, Seattle. Dr. Trudy, thank you very much for that great presentation. We'll certainly share this information with our IR folks and encourage them to perform this procedure for us. While it's a small proportion of your patients, you do have patients that have the distal obstruction down in the SMD. And I understand that all but one patient was successful in terms of the deployment, so you were able to find a target. But could you comment on how those patients did long-term in terms of being able to drain all of those tributaries?
Yeah, the key thing is, picking the right patient to send to IR and what can they do. I review all the cases. If it's straightforward, I just make the appointment. If it's someone that I think may not be stentable or doesn't have a good target, then we do a quick review for their interventional colleagues. They look at their scans chronologically and to see, is there any other outlet that can potentially be stented. So it's all, geographic mapping like it is for all radiologists. So.
Thank you. We're going to go into the Noni Lowry right now, I think.